Hey guys, um, we are going to be talking about melanocytic lesions today. And, I apologize that I had to record this session and share it with you all, not making sure that, at least you guys have the recorded session if I'm not available in person to teach you guys this. So what we will be dealing with today are essentially high yield melanocytic lesions, which can be asked in your boards. Melanocytic pathology is a complicated subject, but we're going to be dealing with the high yield topics. So this is the first slide that I'm sharing with you is of a compound Spitz-Nevis. It's a pretty frequently asked question. This lesion, as you can see, has a very well circumscribed architecture. It is very symmetric. Often they present as these well circumscribed papules with epidermal acanthosis and hyperplasia. And you can see that the lesion has nests on either side. The well circumscribed architecture of the lesion is very important for determining the factor that this lesion is benign. And then you can see these vertically oriented nests, which are oriented perpendicular to the epidermis. It's like, rain shower coming down from the clouds. Very vertically oriented nests. Most of these nests, they also have retraction from the adjacent stroma. So the space is pretty classic for a Spitz-Nevis. You can see the space surrounding the vertically oriented nest. Additionally, you have these amorphous pink eosinophilic structures in the epidermis and in the dermoepidermal junction, which are referred to as camino bodies. So these are the pink eosinophilic structures. These camino bodies, indicate a benign spitzoid proliferation. So these are camino bodies. You can have one here, there is another one here, another one here, another one here. And the cells, if you look at it, they do look cytologically atypical, and that's pretty classic for a Spitz neoplasm. They have this abundant eosinophilic cytoplasm with vesicular nuclei and prominent nuclei, and kind of like a spindle and an epithelioid morphology. So the cytology can be pretty alarming, but if you look at the architecture, the well-circumscribed nature, the vertically oriented nest, the retraction from the surrounding stroma, and the camino bodies make this lesion benign. So this is a completely benign compound Spitz-Nevis. Okay, the next lesion that is also extremely high yield, we're going to talk about this, is a pigmented melanocytic process. This shares overlapping features with a Spitz-Nevis, which is heavily pigmented and is referred to as pigmented spindle cell nevus of Reed. One of the second order questions they can ask you regarding a pigmented spindle cell nevus of Reed is the fact that these lesions, they have NTRK3 fusion. So NTRK3, NTRK3 fusion is a defining genetic event in the pigmented spindle cell nevus of Reed. And overall, again, these lesions are pretty well circumscribed. They again have that nice epithelial hyperplasia overlying it. You can see that the lesion is ending on nests on either side. It is very symmetric. It looks similar to a Spitz-Nevis, except that you can see that there is retraction of the nest from the surrounding stroma. Again, the similar kind of cytology, very large cells. But the defining feature of this lesion is, again, the heavy pigmentation. So the melanocytes are heavily pigmented. They have coarse melanin pigment in the cytoplasm. And there is also heavy melanin pigment dropout in the stroma. So the pigmented nature is the one that stands out from a conventional Spitz-Nevis. So this is pigmented spindle cell nevus of Reed, which harbors the NTRK3 fusion. So this is the next important board question. The next lesion we're going to deal with is also very high yield, and that is a compound halo nevus. So halo nevi are benign melanocytic lesions which have an associated lichenoid lymphocytic inflammatory component, which can make the melanocytes difficult to basically see, and they kind of hide and they amidst this lymphocytic infiltrate. The architecture of the lesion again is very symmetric. It has a dense lichenoid inflammation. So in low power, this almost looks like a lichenoid infiltrate, like lichen planus. The edges of the biopsy in a halo nevus, as you can see over here, it always turns. Whenever it's a shaved biopsy, the edges like turn like this, and this can be a hint that the lichenoid infiltrate is probably hiding something. And you can see that these are the lymphocytes. These are the smaller cells, the lymphocytes, and they're hiding these melanocytic nests. So we can see the nests Here, the cells have, again, occasional prominent nuclei, some multinucleated melanocytes. There is melanin pigment indicating there is a melanocytic lesion in the background. So just as comparison, these are your lymphocytes. These are your lymphocytes, and what they are hiding are the melanocytes. So this is a compound halo nevus, not a melanoma. So this is also a completely benign lesion. Another lesion, which is high yield, which can be asked, is kind of like a degenerative change which occurs in a nevus and is referred to as balloon cell change. When a balloon cell cytoplasmic degeneration of the melanocytes is prominent, the nevus is referred to as a balloon cell nevus. So what you can see here is, again, a conventional compound melanocytic nevus. Again, look at the architecture of the lesion. It's very well symmetric. So for all melanocytic lesions, looking at the symmetry of the lesion is important. But when we go up on high power, we will see that many of these melanocytes, they have cytoplasmic vacuoles. They almost look like sebocytes because the melanocytic nuclei is being crenated, but that's a secondary cytoplasmic degeneration which is occurring in the nevus, and that is referred to as a balloon cell change within a nevus. So this is a balloon cell nevus, and this refers to the classic morphology of the balloon cell change in the melanocytes. So you can see the cytoplasmic degeneration. These cells are looking like sebocytes, but they are mixed with the more conventional appearing melanocytes, and then you have the second cell population with the balloon cell change. So that's a balloon cell nevus. Let's go to the next high yield entity, which is asked, which is your blue nevus. So the blue nevus, they look pretty distinct from your classic melanocytic nevus cells because the cells forming the blue nevus are not round in morphology, so they're not epithelioid, but they are these spindle dendritic melanocytes. So you can see that these cells, they have elongated nuclei with the melanin pigment in the cytoplasm. So these are the spindle and dendritic melanocytes of a blue nevus. You can see in here, and the melanin, the coarse melanin pigment in these particular cells. So the overall lesion can, be a little deceptive. It can look like an area of busyness in the dermis with some dermal sclerosis. So you can see that this is the defining portion of the lesion, and the cells themselves, they have variable melanin pigment, so they can be minimally pigmented to heavily pigmented, but they have these kind of elongated spindle dendritic nuclei with the melanin pigment. So this is a blue nevus. This is a conventional blue nevus. Now, if you see something like a blue nevus in your slide and you don't have blue nevus in your multiple choice options, and the things that look like blue nevi are referred to as dermal melanocytic hamartomas. So included in that category of lesions is essentially entities like nevus of Ota or nevus of Ito or even your Mongolian spot. The differences in Mongolian spot, the blue nevus-like melanocytes, they're not going to be superficially located in the dermis, but they're going to be in the deep dermis and the subcutaneous fat. But the cytology is the same. So what am I saying is that nevus of Ota, nevus of Ito, or Mongolian spot, they all look like blue nevus. So this was a patient who presented with pigmented lesion, which was on the upper back of the patient. And you can see that this looks exactly like a blue nevus. It has spindle dendritic melanocytes with this coarse melanin pigment present in a slightly sclerotic dermis. But this was a nevus of Ito in this patient. Looks very much like a blue nevus. And so this is nevus of Ito or nevus of Ota. And if this was a Mongolian spot, you would see the similar dendritic melanocytes, but they would be in the deep dermis and in the subcutaneous fat. An important variant of a blue nevus, which is again an important board question, is your cellular blue nevus. So they love to ask you cellular blue nevus, and they will always put the differential diagnosis of melanoma in there. So whenever you have things like a Spitz nevus and a melanoma and the differential, it's, likely going to be a Spitz nevus, then, they want you to understand what a Spitz nevus looks like, what a blue nevus looks like. Blue nevus, like melanomas, are extremely, extremely rare entities. So, I would not pick that up as an option unless until there is strong convincing evidence of that. So blue nevus, so this is a cellular blue nevus. Cellular blue nevus have this kind of dumbbell-shaped morphology. So you can see this kind of bulbous extension of the lesion into the deep dermis and the subcutaneous fat. The lesion itself has a biphasic architecture. Now, what does that mean? it means that the superficial portion of the lesion looks like a conventional blue nevus. So you can see that these are your dendritic spindle melanocytes with less melanin pigment, not very prominent, but this melanin pigment can be variable. It can be prominent as well. But the superficial portion of the lesion is hypocellular. So it looks more like your conventional blue nevus. But then the deeper portion, on the middle portion of the lesion, has this more cellular proliferation of compact nodules of spindle cells, which have minimal cytoplasm, minimal melanin pigment in the cytoplasm. So they're not very pigmented, and it's very cellular, very compact. And presence of these cells, which are known as the multinucleated wreath-like cells, so cells like this, which have, multiple nuclei in them, is also a classic morphology of a cellular blue nevus. So again, we are looking at the architecture of the lesion, this kind of a dumbbell-shaped morphology with bulbous extension of the nodule into the deep dermis and the subcutaneous tissue, the biphasic morphology, wherein the upper portion of the lesion is much more hypocellular, variably pigmented, and then you have this more compact, nested, and fascicular proliferation of these cellular spindle cells, which if you just look at them, they don't even look like melanocytes. They're that cellular, very minimal melanin pigment. And then very often you will see pleomorphism in the lesion, characterized by the presence of, occasional multinucleated wreath-like cells, like the cell that I had, previously showed you, like this over here. This multinucleated cell is, pretty classic for, this particular kind of a lesion. So that's your cellular blue nevus, and blue nevus like melanoma would be a wrong answer. And again, these blue nevi, they show infiltration into adnexal structure. So that's not uncommon. It is okay to find like couple of mitoses, but more in the superficial portion of the lesion. Deep mitosis should be alarming, but again, deep blue nevus like melanoma are extremely rare entities. So, I would highly think twice before picking that up as your correct answer. So this is your cellular blue nevus. The next entity we are going to talk about is your congenital nevus. So congenital nevi, when we refer to something as having a congenital growth pattern, what it essentially means is that these nevus cells are kind of splayed out entirely in the dermis, and they're growing around the adnexal, especially the follicular units. So you can see that this is a compound melanocytic nevus. So you have these nevus cells which are at the dermoepidermal junction, and then you also have nevus cells in the dermis. But if you look at the growth pattern of the lesion, it's growing. The nevus cells are kind of oriented parallel to the epidermis, growing in between and among the collagen bundles, all throughout the dermis, growing around this hair follicle. That is referred to as a congenital growth pattern of the lesion. So when we see this, we may say that the nevus has a congenital growth pattern that may or may not always translate into the fact that whether this was a congenital nevus or not. But this is how congenital nevi, which have been present from birth, look like. They're often compound. So they have melanocytic nests at the dermoepidermal junction and also have the dermal nests. And the dermal nests, they do exhibit nice maturation, which essentially means that the nevus cells in the top portion of the dermis will be bigger, but then the nevus cells in the bottom portion of the lesion are much more smaller. So the nuclear size decreases, the amount of cytoplasm decreases, and then they are present in between and among the collagen bundles, often growing parallel to the epidermis and also growing around adnexal follicular structures like the hair follicles, as you see in here. So that is your congenital nevus. The next entity that we are going to talk about is deep penetrating nevus. So deep penetrating nevus is also a very important board question. The deep penetrating nevi, so cellular blue nevi have a dumbbell-shaped morphology. So they have that dumbbell-shaped bulbous nodular extension to the deep dermis, whereas the deep penetrating nevus has a wedge-shaped morphology, so like an inverted triangle. And deep penetrating nevi are pretty interesting lesions. So the cells of a deep penetrating nevus, they often occur in combination with a conventional nevus. So it's not uncommon that in the background of this lesion, you would see conventional nevus cells. So something which looks conventional. Typically, these lesions are heavily pigmented, and you see this kind of coarse melanin pigment in the cytoplasm of the cells as well as in the stroma. What makes a lesion deep penetrating is the presence of a second cell population within the lesion. And this second cell population of the lesion are the cells which have more amount of epithelioid and pigmented cytoplasm. So cells which are larger, so cells like this. So this is a classic deep penetrating nevus cell. The cells which are larger, they have more epithelioid, larger epithelioid nuclei and more amount of cytoplasm which is pigmented. So remember the deep penetrating nevus, the architecture of the lesion, it's a wedge-shaped proliferation. There is often a conventional nevus component within the lesion. The lesions are often heavily pigmented. And then you have a second cell population. So you can actually see at low power. These are probably the conventional nevus cells, and these cells right in over here, these lighter areas, when you go up on high power, these cells, they have much more amount of cytoplasm. They are heavily, they have coarse melanin pigment in the cytoplasm of the cells. So now what is the importance of recognizing a deep penetrating nevus? Deep penetrating nevus are now referred to as a melanocytoma, which basically means that they harbor a second genetic mutation, which is the beta-catenin activating mutation. So when we do the beta-catenin stain in these lesions, and I'm going to show you an example of that. This is a beta-catenin immunohistochemical stain. The lesional melanocytes, the nuclei, they strain very strongly. So you can see that there are conventional nevus cells in the background, but if you compare the staining of the nucleus of the non-mutated cells to the mutated cells, you see that the nuclei are much more darker staining. So these lesions have a gain of function activating mutation of the beta-catenin gene. And so deep penetrating nevus, what are the questions they can ask you? These are melanocytomas. They harbor a second genetic event, which is the beta-catenin activating mutation. And hence, these lesions come in the intermediate melanocytic category, which means that if the mutated lesional melanocytes are allowed to persist and they involve either the peripheral or the deep margin of the biopsy, then they can get another hit and then transform into a more aggressive lesion like a melanoma. And hence, if a deep penetrating nevus has not been completely excised, we will strongly recommend complete removal of these lesions. So this is the beta-catenin mutated melanocytes, much more darker nuclear staining as compared to the background nevus cells, which have lighter staining. So that is your deep penetrating nevus or a deep penetrating melanocytoma. The next kind of melanocytomas or melanocytic lesion we are going to talk about are bapomas. So bapomas are kind of spitzoid melanocytic lesions which have loss of the tumor suppressor gene, which is your BAP1 gene, which is a BRCA-associated protein 1 gene. So bapomas or BAP mutated nevi. So these lesions have a classic low-powered appearance. They are polypoid and well circumscribed. So you can see a polypoid morphology of the lesion. They again have a conventional melanocytic nevus component. So you can see these conventional melanocytes within the lesion. But then there is a second population of these cells, as you can see in over here, which have much more abundant eosinophilic cytoplasm with larger epithelioid cells and often prominent nuclei, as you can see in here. It's not uncommon to see like a mitotic figure. You can see a mitotic figure here, right in the upper to the middle portion of the lesion, again, not in the deeper portion of the lesion. So you can see that these are the conventional melanocytic nevus cells. So if you compare the nuclei, they're much more smaller. They have much less cytoplasm as compared to these cells, which have much larger nuclei and abundant amphiphilic to granular cytoplasm. So these are the BAP mutated cells. So there is loss of tumor suppressor gene, which is your BAP1 gene. And again, you can confirm this BAP mutation by doing an immunostain. So we can do a melanocytic immunostain, which is for your BAP1 state. And that will basically confirm that there is loss of the loss of nuclear expression of the BAP1. So I can show you an example of that. So let's see an example. So this is the BAP immunostain. And you can see that the conventional nevus cells, which are these cells, they have nuclear expression of BAP1, which means that they are normal. But then if you come to the mutated melanocytes, which are these cells, they have lost the nuclear expression of BAP1. That means that this is a BAPoma. So the nevus cells have nuclear expression of BAP1, and then the mutated melanocytes have lost the BAP1 expression. So this is a BAPoma. Now, these bapomas are single lesions. That means they are sporadic lesions. We often recommend removal of these lesions, but there is nothing more to do. But if the patient has multiple such cutaneous bapomas, or if there is a strong family history of having these lesions, or if the patient has uveal melanoma, then you have to consider the BAP1 tumor predisposition syndrome, which is an autosomal dominant disorder. So this patient then may be harboring a germline mutation of the BAP1 gene, which increases the risk of in these patients of having other malignancies. So, for example, they can have uveal melanomas. They can also have other tumors like non-melanocytic tumors like mesotheliomas, lung cancers. So these patients need to have genetic counseling. So that is the significance of finding these particular lesions. They itself are intermediate melanocytic lesions. They're not melanomas, but we do recommend complete removal of these lesions. The last entity which I'm going to be talking about in these lesions is a neurotized nevus. So a neurotized nevus is a senescent nevus. It's a nevus which is on its pathway, which is out, and the melanocytes, they gradually assume a more neural morphology. So they resemble more a neurofibroma. Again, these lesions are very well circumscribed, often have a polypoid morphology, and you have these conventional melanocytic nevus cells. You can see the conventional melanocytes, and then there is a second population of more of these neuroid spindle cells within the lesion, which look like a neurofibroma. So these look exactly like a neurofibroma, but they are mixed with the more conventional melanocytic nevus cells. So that's a neurotized nevus. It again indicates a degenerative change within the lesion. So these lesions are completely benign. Okay. The next, continuing again on your high yield entities, which are going to be asked in your boards. So we are going to go into the next particular lesion. So I'm going to be talking about your persistent or your recurrent nevus. So give me a minute to basically recognize that particular slide. So persistent or a recurrent nevus. Okay. So it's right here. So this is a very, very important board question. So persistent recurrent nevi, they will often clinically look like melanomas. So they are often referred to as pseudomelanomas. And not only clinically can mimic a melanoma, but even under the microscope, very frequently they will exhibit the architectural atypia, which is worrisome for a melanoma. So hence referred to as a pseudomelanoma. Again, when you get a persistent recurrent nevus or a pseudomelanoma, in your multiple choice, and they also have a conventional melanoma in the differential diagnosis, the answer much more likely is going to be a persistent recurrent nevus. The first important point of recognizing this lesion is to recognize the scar within the lesion. So the low power view is very important. So on low power, you can see this kind of a dermal scar. So this is the scar within the lesion. There is effacement of the reedy ridge pattern overlying it. So you can see the dermal scar in here, the effacement of reedy ridge pattern, and right overlying the dermal scar, you have this melanocytic proliferation. These cells obviously have cytologic atypia. They have abundant melanin pigment, often with prominent nuclei. And the architecture of the lesion is also bizarre because you can see interlentiginous proliferation with some pagetoid extension. But everything is overlying a scar, and hence it is a persistent recurrent nevus. Now, in a persistent recurrent nevus, it's very difficult to determine dysplasia within the nevus. So persistent recurrent nevus would look like a persistent recurrent dysplastic nevus. And it is difficult to grade the degree of dysplasia in a persistent melanocytic neoplasm. So mild, moderate, or severe, it's difficult to grade that because the architecture is distorted. The important thing is that this is not a melanoma. So what do you recognize is there is a scar in the dermis. There will be lymphocytic inflammation accompanying the scar, and overlying the scar, you will see the atypical melanocytes. So everything is overlying the scar. So that's your persistent recurrent nevus or a pseudomelanoma. A very important word question. The next thing we are going to talk about is your solar lentigo. So solar lentigo are pretty frequently encountered lesions in sun-damaged skin. These lesions have what is referred to the dirty feet pattern. So you will see marked sun damage. So you can see solar elastosis, and overlying this, you can see these club-shaped, elongated, reedy ridges, which are pigmented. So these are called your dirty feet, which have emanating from the epidermis. So these club-shaped reedy ridges, which are pigmented, which are coming down from the epidermis. So that's so it's much more better over here. So you can see the sun damage and these club-shaped, elongated, reedy ridges, which are heavily pigmented. emanating from the epidermis. So there is no melanocytic proliferation within a solar lentigo. What causes the pigmentation of the lesion is actually the epidermal hyperpigmentation, but there is no melanocytic proliferation. There is one single melanocyte right over here. So what are the things that can look like a solar lentigo? Remember that epidermal pigmentary disorders like your Kitamura's disease, which is reticulated acral pigmentation, and Dowling-Dego's disease, which is your reticulated pigmentary anomaly of flexures, as well as Gali-Gali disease, except that it will have superimposed acantholysis, will look like a solar lentigo, the dirty feet pattern. Solar lentigo-like proliferation can also be seen in Becker's nevus, also Cafe-Ale macule. So these are the things that can mimic a solar lentigo. The dirty feet with epidermal hyperpigmentation. Remember the pigmentary anomalies, Dowling-Dego's and Kitamura disease. Becker's nevus can have that, but obviously in a Becker's nevus, you will see hematomatous smooth muscle bundles, which are increased in the dermis, along with this kind of lentigo-like epidermal hyperpigmentation and a Cafe-Ale macule. In a Cafe-Ale macule, you also get what are known as the giant melanosomes, or the coarse melanocytic granules in the cytoplasm of the melanocytes. That's another feature of Cafe-Ale macule, but the background looks like a solar lentigo. Again, a solar lentigo has no melanocytic proliferation within it. On the other hand, if on sun-damaged skin, you do get melanocytic proliferation in the background of a solar lentigo. So you can see here again, this is a nice shave biopsy, and you can see marked sun damage, but in over here, you're now seeing proliferation of asymmetric proliferation of junctional melanocytes. This is a melanocytic nest. Then you have single melanocytes, which are in a lentiginous proliferate pattern, proliferating in the epidermis. So that is melanoma in situ, which is lentigo maligna type. So all of this is the melanoma. So you can see these are the nests of melanocytes. This is a nest, this is a nest, another nest, and these are the enlarged melanocytes. You can see that they are proliferating in the epidermis. This is pretty much a lentiginous pattern. So lentigo maligna melanomas, they have minimal pagetoid proliferation. They have lentiginous asymmetric junctional proliferation of single and nest of melanocytes. So you can see these are the solitary melanocytes, this one, this one, this one. They're joining each other, which is never good. There is limited pagetoid proliferation, and then you see asymmetric nests as well on sun-damaged skin. So this kind of melanocytic proliferation on sun-damaged skin as single and nest of melanocytes is classic for lentigo maligna type of melanomas. They have minimal pagetoid proliferation. The next one we are going to talk about is the next kind of melanoma, which is a superficial spreading melanoma. So superficial spreading melanomas, they have the lentiginous proliferation as well as pagetoid extension. So you can see these are the large single and nests of melanocytes, but you can see the nice pagetoid proliferation of the melanocytes into the upper levels of the epidermis. You can see these pagetoid melanocytes in here, numerous pagetoid melanocytes in this particular field. So this would be your superficial spreading melanoma. So single and nest of melanocytes with both growing horizontally, kind of like horizontally because they're growing in the epidermis in a horizontal fashion, but also showing pagetoid proliferation. So that is your superficial spreading melanoma. The next kind of melanoma, let me see if I can show you another slide of your superficial spreading melanoma. This is another one. So you can see this is a nice shave biopsy. Melanocytic lesions are much more better evaluated on shaves as compared to punches. So you can see this is a beautiful superficial spreading melanoma. You can see the single and nest of melanocytes varying in size and shape, having a contiguous proliferation in the epidermis with marked pagetoid extension. So these are the pagetoid melanocytes. This is no longer just an in situ. This is also an invasive melanoma. So it has invaded into the dermis. So these are the nests of melanocytes that have invaded into the dermis. So, for all invasive melanomas, we have to give them the Breslow thickness. So the Breslow thickness would be measured from the granular cell layer to the deepest point of invasion. So we will put our oculometer in our microscope and measure the thickness or the Breslow thickness. So the top, the 0 point would be here, and this would be the bottommost point of invasion. So that is the Breslow thickness. The Clark's level refers to which level of the dermis is involved. So a Clark's level 1 is obviously melanoma in situ. Clark's level 2 would be if just a few cells have come into the papillary dermis. That would be like a level 2. If the invasive melanoma cells have filled and expanded the papillary dermis like this, so they have filled and expanded the papillary dermis, that's a level 3. And if the melanoma cells have involved the reticular dermis, so if you have tumor cells like right here, which are involving the reticular dermis, then that would be a level 4. So I'll again discuss this breast lobe thickness later. And level 5 is very rare, is when the melanoma cells are in the fat, subcutaneous fat. So level 1 is melanoma in situ. Level 2 is a couple of cells involving the superficial papillary dermis. Level 3 is when the invasive melanoma cells have filled and expanded the papillary dermis, and level 4 will be when it involves the reticular dermis, and 5 is in the fat. So that is your very beautiful example of a superficial spreading invasive melanoma. One of the most difficult, challenging melanocytic lesions sometimes can be an acral melanoma. So let's talk about an acral melanoma. So acral melanoma, they arise on the acral sites, the palms and the soles of the feet, and they can be very, they are high risk aggressive lesions, can sometimes in the early stages be very difficult to recognize. And they harbor a different kind of mutation, which is a c-KIT mutation. So, as compared to your more conventional BRAF and NRAS mutations of your superficial spreading and lentiginous melanomas, in acral melanomas, you have the c-KIT mutation. So this is the acral site, obviously. You will recognize the lesion from its acral site, the thick cornified layer, the stratum lucidum, and the pattern of pigmentation in the cornified layer is contiguous. So you can see coarse melanin pigment in a contiguous fashion in the cornified layer. So that is, a clue that there may be a more challenging melanocytic lesion down beneath, a more a malignant lesion down beneath. And you can see that there are nests of melanocytes, which are again varying in size and shape, showing phagocytic proliferation. And this also has invaded into the dermis. But this is an acral lentiginous melanoma, and they harboring the c-KIT mutation. Again, the further classification of this melanoma would be like any other melanoma. So breast lobe thickness Clark's level is all that would be reported in this melanoma. Another type of the melanoma in terms of its growth pattern is a nodular melanoma. So a nodular melanoma, they present as these expansive nodule filling and expanding the dermis. They have limited radial growth phase, which means that they do not have much of lentiginous proliferation in the epidermis, but they have a vertical growth phase, which means that they present as expansile nodules invading into the dermis. We typically don't classify the type of melanomas. The only one that I would like to state is a lentigo maligna or the acral lentiginous melanomas. This is a melanoma. Its prognostication depends on all the other similar features to other melanomas. So the breast lobe thickness and the presence and absence of ulceration are the two most important prognostic defining criteria, and we would report other findings in melanoma. So what are the findings that need to be reported in all melanomas? So obviously the breast lobe thickness and ulceration are the two most important things. The other findings that we do report are the Clark's level, though the Clark's level may not be reported. Breast lobe thickness obviously needs to be reported. Clark's level, we discussed about it. It does not always need to be reported in your synopsis, though we typically do report it. The other things, which is obviously ulceration, dermal mitosis, presence and absence of lymphovascular invasion, presence and absence of regression, which I will talk about what it means, and neurotropism, as well as presence and absence of desmoplasia and the pathologic stage of the tumor. We also do report an associated lymphocytic response, if it is brisk or non-brisk. So this is an associated inflammatory lymphocytic response within the tumor, and this would classify as non-brisk. So if I'm giving the prognostic criteria of this lesion, then the most important will be the breast lobe thickness, which will be measured from the granular cell layer to the bottommost part of the invasive melanoma cells, which would be down over here. This would be a level 4, Clark's level 4 melanoma. It does not have ulceration. I don't see any lymphovascular invasion. There is no regression. Then I would count the mitotic count within the lesion. So I will go up on high power field, 40x. We'll look at the dermal mitoses and count them in like 8 fields, which would be the dermal mitotic count per millimeter squared within the lesion. And so this is a stage 4, and my guess is that this would be at least more than 3 millimeter. So this would be basically like a PT3A melanoma. Remember, the lesions which are up to 1 millimeter will be PT1. PT1A are lesions which are less than 0.8 millimeter and not ulcerated. Any lesion which is ulcerated, or if it is 0.8 millimeter up to 1 millimeter, is going to be a PT1B melanoma. 1 to 2 millimeter is going to be a PT2 melanomas, and then your 2 to 4 millimeter is going to be a PT3 melanoma, and a greater than 4 millimeter is going to be a PT4 melanoma. So that's how we basically classify these lesions. Okay, so so that is your nodular melanoma because it has more of a vertical growth phase. I can actually show you a slide where exactly we have measured the Breslow thickness. So let me pull out an example of that. Give me a minute. Okay, so here, so there is an annotated figure right here, which is showing you how we measure the Breslow thickness. So this is a superficial spreading melanoma, as you can see, and the Breslow thickness would be measured from here to the deepest point of invasion, which would be here. So you can see that this is the invasive melanoma, and it looks like it is around 0.6 millimeter in thickness. So that will be the Breslow thickness, and that's how we measure it. Okay, let's show you the next one. Let me show you some of the other prognostic factors that I was talking about in a melanoma. So this is another example of an invasive melanoma. So you can see this is a beautiful classic melanoma. It has both the superficial spreading and a nodular growth pattern. Again, the Breslow thickness would be probably measured from here till here, which would be the deepest point of invasion. This is a level 4. It is not ulcerated. This did come up to be 1 millimeter. So this would be a PT1A tumor. I'm sorry, PT1B, because it is 1 millimeter. It's greater than 0.8 millimeter, even though not ulcerated, but because it's 1 millimeter, it will become a PT1A, PT1B tumor. And there is no lymphoblastic invasion or regression in this particular lesion. Okay, so the next one, I'm going to show you another example, which would be what does the ulceration in a melanoma mean? So this is an ulceration. So you can see that in this particular lesion, you have the normal epidermis, and then there is loss of the epidermis in here. So that is ulceration. So that would upgrade the stage of the lesion in any PT1, PT2, PT3, PT4 from an A to a will upgrade it. So this will be a B tumor. So you can see the presence of ulceration. Okay, so now let me show you what exactly regression means. Regression means that there was melanoma and no longer there is melanoma in the lesion. So essentially what you can see in over here is that, okay, let's see an example in this lesion. So let me show you where the melanoma was there, and then you don't have the melanoma. So all of this is dermal fibrosis with pigment dropout and inflammation, but there is no melanoma. So here there was melanoma, there is a nest in over here, and then this melanoma suddenly went away. And what we are left with is just dermal fibrosis, lymphocytic inflammation, as well as pigment dropout. So that would be the regression in the melanoma. So you have the melanoma in here, and then you have dermal fibrosis with pigment dropout and inflammation, and that is, invasive melanoma. That guy, so you can see that there is the, the nests of melanocytes, and then you have the dermal fibrosis. So basically, what does regression mean? Regression means you had a melanoma, and now you no longer have a melanoma. So you had the melanoma in here, and your body basically responded. Okay, so you have the melanoma, and then you have the dermal fibrosis with the pigment dropout and lots of melanophages. So what makes up regression is no melanoma, dermal fibrosis, inflammation, and the pigment dropout. So that's the regression. Sorry, there was a lot of confusion in explaining you that, but hope you guys understand that. When we have a lesion which is completely regressed like this, wherein you don't see any melanoma left behind. In this, we did have some melanoma, so that was melanoma with regression. But if you just have this, if you just have the dermal fibrosis with pigment dropout and no tumor and just the inflammation, that's referred to as tumoral melanosis. And tumoral melanosis is a common histologic finding that we see in patients who are on immunomodulator therapy. So patients who are, either get the neoadjuvant therapy for treatment of melanomas, and if their body responds, the melanoma goes away, but what is left behind is fibrosis, inflammation, and pigment dropout. That's tumoral melanosis. So if you see something like this, regression equals tumoral melanosis if you don't see the melanoma, and that can be a response to immunomodulator therapy. Okay. Let me show you an example of lymphovascular invasion. So this is a bad nodular melanoma. It's at least 4 millimeters in thickness. So it is like a PD4B. It is ulcerated. You can see these melanoma cells are inside the lymphatic. So that's invasive melanoma with lymphovascular invasion. Perineural invasion is something which is not very common in melanomas. It's understand it's a spindle cell desmoplastic kind of melanoma, but this is perineural invasion. So you can see a nerve. We don't typically report the thickness of the nerve. We just report whether perineural invasion or neurotropism is present or not. Melanoma is wrapping around this nerve cells. The next important slide, which I'm going to show you, is a desmoplastic melanoma. This is a really important board question. Desmoplastic melanomas typically have the overlying epidermis will show you the in situ component of the melanoma. So the lentigo malignum, the desmoplastic melanomas typically arise on the sun-damaged skin, so arise in association with your lentigo maligna melanomas, but not always. So the overlying epidermis is showing you the melanoma. In this case, it is not very pigmented, so it may be difficult for you guys to see, but all these enlarged multinucleated cells are actually the tumor melanoma cells. You can see pagetoid proliferation in here. So this is the melanoma overlying on the top. But then what you see in the dermis is very subtle proliferation of these enlarged, like hyperchromatic spindle cells, which are actually going down to the base of the tumor. It is almost all tumor over here. Now, what gives you a clue for the desmoplastic melanoma are these trailing lymphoid aggregates, so these lymphocytes. These lymphocytes are hiding the very subtle invasive tumor cells, which are all in here. So this is all the tumor cells, and these are all the lymphocytes which are hiding this. The desmoplastic melanoma, the problem is that if you do not recognize the invasive component of the lesion, and again, the clue of that can be the trailing lymphoid aggregates, and you do one melanocytic marker, like for example, you just happen to do the melanine in this lesion, melanine or a MART1. So what does a melanine or MART1 do? It will only highlight the in situ component of the melanoma. So all the red cells are the melanoma cells, and you can see that it is only highlighting the in situ component of the melanoma. It's not highlighting the invasive component of the melanoma. So you can completely ignore the invasive component and just call it melanoma in situ, when in fact, this is an invasive melanoma, which is going down to the base. So it could be even deeper. So this is the S100 or the SOX10 stain. In this case, this is a SOX10 stain, and you can see that it highlights the invasive component. So whenever you are thinking about desmoplasia, you have to do S100 and SOX10 and not melanine, MART1, and HMB45, which will only stain the in situ component of the lesion. So S100 and SOX10 have to be added. And desmoplastic melanomas, they look like an atypical spindle cell proliferation, which can be minimally cytologically atypical in the dermis, hidden by those lymphoid aggregates, which are called the trailing lymphoid aggregates. And then the last thing which I'm going to be talking about is your metastatic melanoma. So a metastatic melanoma, obviously is going to be a process which is going to be entirely within the dermis. Now, when you're looking at a metastatic process, it is not very challenging to recognize it if it is pigmented. So then you know that this is a pigment forming tumor, which is going to be a melanoma. But the problem is when it is not pigmented. So that recognition of a metastatic melanoma relies heavily also on the cytology of these cells. So what you would see is a nested growth pattern. So you have these nests of these tumor cells. And one of the classic cytology, which I always tell my students, is this prominent cherry red nucleoli. So you can see these tumor cells, they have this really bright prominent red macronuclei, so like cherry red nuclei, almost like the owl's eye, which is staring back at you. So prominent, a nested growth pattern of tumor cells, with the tumor cells having prominent red macronuclei, or the cherry red nuclei, is a classic feature of a metastatic melanoma. So again, you can see these nests of tumor cells with prominent red macronuclei, the cherry nuclei. So that is your metastatic melanoma. And with this, I'm going to end. I'm sorry for all the background noise. I'm actually recording this in the Delta Sky Club waiting for my flight. And hopefully this was high yield melanocytic pathology to you. Guys, I'll subsequently share a study set as well. So, go through these lesions. I'll probably email you the list of the entities and then, go back to this Zoom session, which is available, and, remember these lesions. These are the high yield melanocytic stuff, which is asked in your bones. Thank you so much. Have a great day.